In the U.S., prostate cancer is the most common solid malignancy and second cause of cancer death in men. Office-based transrectal ultrasound prostate biopsy has been the gold standard, making the diagnosis in roughly 2.6 million men since 1995 in the U.S. alone. In the millennium, however, prostate MRI has become a must-use tool to identify most tumors, providing perspective and guidance prior to biopsy. Here are some of the differences between the two approaches we can take in prostate biopsy procedures. Trust biopsies became popular as they are straightforward, requiring only ultrasound knowledge. They transitioned well into urologist offices. However, trust biopsies carry several caveats, among them risk of rectal bleeding, UTI, and urosepsis. Furthermore, their sampling profile is limited in scope, specifically in transitional zone. The transperineal approach to sample the prostate contains several advantages, such as percutaneous approach through sampling, rectal avoidance, which translated into lack of rectal bleeding, and very uncommon infections, so antibiotics are rarely needed. However, it is considered an operative procedure that requires general anesthesia. The advances in MRI prostate imaging, along with the U.S. Task Force screening recommendations, propelled the challenge in the paradigm to do better. Limit harm when sampling the prostate. This challenge leads us to focus of transperineal MRI ultrasound fusion biopsies. Innovate in 2014 with a local perineal anesthetic block that allowed for in-office execution without general anesthesia, as it will be shown later in this video. Herein, we present a patient who underwent an MRI ultrasound transperineal fusion biopsy. As shown in the screen, this 72-year-old male had a PSA of 9.1 with a normal digital rectal examination. A multiparametric MRI was ordered. In the MRI, the images revealed 11.5 millimeter hypodense lesion. With restrictions and contrast enhancements, pyrids 4 on his left mid-peripheral zone. The prostate volume was 38.7 cc's. There were also bilateral pyrids 3 lesions as shown in the video. The development of the biopsy plan represents the initial step, followed by incorporation of this one into the Focalix fusion device. The patient was instructed to administer an enema the evening prior and morning of the procedure. The procedure starts with transperineal anesthetic block. Superficial block is performed using 1% lidocaine just above the anal verge towards the reefy on both sides. The transrectal ultrasound is advanced. The probe is secured to the stepper followed by grid placement. The spinal needle with lidocaine is advanced through the grid under ultrasound guidance to block both nervovascular bundles shown. The co-registration begins by transverse or sagittal scan of the prostate. What follows is the outlining of the gland by using Focalix fusion device. The fusion is accomplished as biomechanical models matches the ultrasound outlined to the MRI loaded data. Now are depicted the prostate outlined and the regions of interest. The illustration shown depicts the next step, where transperineal prostate sampling will be performed using real-time MRI ultrasound fusion. Now begins the execution of the biopsy. On the top left side, the device represents us with a 3D model of the prostate, regions of interest and coordinates of the biopsy course. On the right panel, we can see how the biopsy is taken from the preset target. The video shows how the target was set up to sample the regions of interest. The bottom left illustrates the exact grid coordinates, where the biopsy needle shall be placed on the grid to hit the targets. The procedure is done systematically until it is completed. Those were the procedure outcomes for this patient. In this example, the biopsy was only positive on Big E 2.5, sampling the peripheral zone from mid-gland to base. A Gleason 4+3 tumor was detected involving 90% of the core. Interestingly, we can gain precise knowledge of where it is positive in lieu of the other negative cores. Taken in context, this helps the decision-making process. Between 2014 and June 2020, we have performed 1,699 MRI ultrasound-guided transperineal biopsies under local anesthesia in the office setting. The median pain score was 3. The median procedure time was 20 minutes. Since 2017, we abandoned the transrectal biopsies. All biopsies in our clinic have been performed using the transperineal approach under local anesthesia. 1,249 have been transperineal fusions and 150 transperineal random. In conclusion, MRI ultrasound transperineal fusion biopsy is feasible, reliable, reproducible, and well tolerated by patients. This approach minimizes the well-described harm associated with diagnosis of prostate cancer. This technique provides several advantages: thorough sampling in office setting, precise diagnostic location, limited adverse events, opens a door for precise MRI ultrasound guided therapies.